Welcome back. At this time, we have our public comment period. At present, we have 4 people who have signed up to give a public comment. I will announce your name and your organization. If you're here in person, please come up to the microphone and begin your 3-minute comment period. If you've dialed in, our moderator will unmute your line so you can deliver your 3-minute comment. I would like to open it up to Dr. Divi Padhe, who leads diagnostic safety efforts at Geisinger. Divi, please come up to the microphone and proceed with your comment.
Thank you, Dr. Puluru. Just to clarify, I no longer I have that affiliation. I worked for over a decade on diagnostic safety. So just a correction, and I apologize that I'm not there in person. I appreciate the ability to share my comments remotely. Please let me know when I can start.
Go ahead and start.
Oh, thank you. Appreciate it. So, Chair, members of the PTAC and officers and the federal partner agencies, good morning. Please allow me to express my gratitude for convening on such a critical, sensitive, and complex subject as patient safety. It sort of breaks my heart to learn that yet another personal exposure and lived experience to patient harm had some part to play in the efforts that led to the organization of this event. I pray that God gives strength and love needed to Mr. Waters and his loved ones to live through this unspeakable pain. And really thank him for sharing his story. You see, no clinician, and I'm preaching to the choir here, so no clinician really enters a clinic or hospital wanting to make a mistake, yet they happen. No system wants to deal with these errors, yet they happen. They happen sometimes because humans inadvertently falter. They do their best, they spend years doing diligent hard work, but yet they can falter when it comes to these things because of things they don't know, things they assume they know, or mental shortcuts they take owing to habit or time pressures. That's unavoidable. To add to that, organizations that have not paid attention to safe design or patient-centered goals complicate the matter. I bring this up to give you context from my own lived experience over the last 10 to 15 years, because I think, as a conclusion to a lot of exposure that I've had in the field, in the trenches out there, I think payment methods are a very strong influence on health systems. I've spent half a decade studying payment models in depth. Actually, coincidentally, I used to very briefly be a senior associate for a contractor for PTAC many, many years ago. And then spent some time, almost a decade in the trenches for patient safety, simultaneously researching it and operationalizing it. How I have seen things are that health systems with billion-dollar revenues often traditionally look at safety as a non-revenue generating cost center. They don't have the time or the bandwidth to encourage reporting or, for that matter, create an environment to proactively address potential safety issues. I think the point I'm trying to get at is we are in a crisis. I say this respectfully, and I don't take this lightly. And for this crisis, I think we need government intervention. A reason I think that a mandate is needed because I think hospitals are ready to do anything that CMS wants them to do. All hospitals have people in charge of length of stay, readmissions, O2E, infection, 5 stars. Anything CMS wants, it gets done. And so I don't, want this to be seen as something over the top, but I urge you, the PTAC, to consider strongly recommending to the Secretary to mandate some basic safety infrastructure. And I have faith that the current administration does not shy away from unpopular opinions or complex policies that might especially be in the larger interest of US citizens. Prior administrations have tried but could not execute. Here, in my view, we have a strong executive, and I propose, and I say this very respectfully, an executive order on patient safety. I propose it to be called the Trump Act or Trump's Action Plan, where T stands for transparency, R stands for reform, U stands for unprecedented, M stands for medical, and P stands for patient safety. So the Transparency and Reform for Unprecedented Medical Patient Safety Act, or Action Plan, if it's an executive order, can urgently convene through HHS, a national office or task force of patient safety, strengthened by experienced, passionate experts and strategists. I mean, let's say Mr. Waters and colleagues can lead this right now from the government. And I don't mean to sound punitive. The idea here is that this mandate may be backed by CMS conditions of participation that we've written about many times. could possibly give the right nudge to health systems who are still struggling after 30 years to find the right ROI to invest in patient safety. It could ask for things like closed loop system, once and for all align the 100+ patient safety organizations to feed data into a national database. And if it is CMS money, taxpayer money, why don't hospitals and health systems publicly report the annual spending on medical claims and settlements? There are a number of initiatives that experts put together in a room can come up with, and it could be executed in the interest of something that has been recognized as a problem, but it appears that nothing has been done from a policy perspective. You see, we're a country where an X-ray can cost $800 at a hospital, and right across the street it is $68. We have been debating site-neutral payments for a decade with the best intents and yet not able to execute it. So that is why in this urgency, I have less faith in maybe some, that it might be the right time for payment models or policy from the traditional sense. And that's the reason I'm proposing an executive order that sort of streamlines things and puts things in order because health systems are struggling with ROI.
Thank you, Divi.
Yep. Thank you. Appreciate it.
You're at your allotted time for your comment. Thank you so much for your passion and your comment and ideas.
Thank you.
Next, we have Dr. Linda Hayes Bennett, who is a doctoral candidate at George Mason University. Welcome to the microphone, Dr. Bennett.
Thank you. Oh, is it on? Is it on? It is now? Hello, I am Dr. Linda Hayes Bennett, and I'm so happy to be here. This has been a fascinating event. I attended all day yesterday as well. I am in my second doctorate, health services research and policy, as well as data analytics. I started my career as a cognitive behavioral neuroscientist during the decade of the brain, studying transition metals in animal models of plaque formation in the hippocampus, iron, copper, and my favorite, manganese. So how that plays into our health at the mitochondrial level, and bottom up, what I call terrain health. I followed my degree in another master's at Johns Hopkins in aging and gerontology, mental health as well. Etiology is what I learned at Hopkins, and I'm 25 years into this journey, and I quip that I'm doing my third doctorate on LinkedIn, because there's a lot of things I'm not allowed to talk about, such as music as medicine, ageism, etc. So what a journey. Disclaimer, my first career, highest level opera singer, 6-figure salary, 15 years, 12 times featured soloist at the Kennedy Center. And you got to be healthy to be an opera singer. So I do study health and what that means. So my questions are at this intersection of preserving human function and resilience before decline occurs. How do we map onto what's going on in patients' lives months, years, even decades before they even arrive at the hospital? So in studying all these systems, I'm interested in upstream interventions, sleep, hydration, oxygenation, activity levels, social connection, spirituality. Let's look at that. Let's define that medically. Music as medicine, physiological triangulation of music, caregiver support that influence physiology long before disease becomes irreversible. So these modern models focus on procedural errors, falls, medication events, documentation failures, but how does PTAC envision upstream physiological and environmental contributors to patient deterioration? Namely, dehydration is a big one, and delirium risk, but hypoxia, chronic progressive hypoxia, lack of activation. So in the evolutionary sense, we evolved. We're the survivors of evolution. So how do we look at these upstream modifiable factors, patient monitoring, so that our problem when they eventually arrive at the hospital is lessened and we have triumphant outcomes when patients really need medical intervention. Thank you
Thank
so
you,
much.
Dr. Bennett.
Yeah.
Next, we have Ms. Gina Hoxie, who is a director at the American Society for Clinical Oncology, or ASCO. Welcome to the microphone, Ms. Hoxie.
Good morning. Thank you all very much. Thank you, co-chairs and members of the committee. I'm Gina Hoxie. I'm our Director of Payment and Access at the American Society of Clinical Oncology. We are a national organization representing more than 50,000 physicians and other healthcare professionals that specialize in cancer treatment, diagnosis, and prevention. We are dedicated to conducting research that leads to improved patient outcomes, and we are committed to ensuring that evidence-based practices for the treatment, diagnosis, and prevention of cancer are available to all Americans. ASCO really appreciates the PTAC's focus on enhancing patient safety through APMs. As you all work to advance APMs and specialty care models, we strongly encourage you to collaborate directly with medical specialty societies that have already developed rigorous, evidence-based standards, measures, and certification programs for safety. Medical specialty societies are uniquely positioned to define what safe, high-quality care looks like in practice. CMMI should streamline its efforts and leverage existing clinician-led certification programs rather than creating duplicative or fragmented APMs. One example that we currently have up and running is called ASCO Certified, which certifies practices One example is ASCO Certified program, which certifies oncology practices that meet strict benchmarks for patient safety, care coordination, and evidence-based treatment delivery. When APMs incorporate professional society-led programs, they are more likely to achieve three critical goals. One, they accelerate safety adoption. Practices that are engaged in established certified programs have already built the workflows and the infrastructure that's needed to ensure patient safety and to improve outcomes. Second, they avoid compounding administrative burdens. We know that this is a huge problem, especially in practices right now. So aligning APM requirements with trusted certified programs means clinicians and practices spend less time navigating redundant reporting frameworks and more time on direct patient care. Finally, they foster stakeholder alignment. So when society-led programs are integrated into federal models, this naturally encourages multiple payers and providers to align around the same high standards of safety. If you need more information on anything, happy to answer. ASCO urges the PTAC to recommend that CMS and APM developers integrate professional society standards and certifications for safety within model designs. Thank you very much for your time, your commitment to transforming care delivery. Thank you.
Thank you, Ms. Hoxie. Next, we have Dr. Patrick Romano, a professor of the divisions of General Medicine and General Pediatrics at the University of California, Davis, and a presenter in yesterday's session 2 on measuring patient safety in value-based care. Welcome to the microphone, Dr. Romano.
Thank you. Good morning. I won't reintroduce myself since I presented yesterday, but I just wanted to offer 6 kind of summary thoughts after listening through the last day and a half of amazing presentations. First, I want to advocate for really safety in every APM. Safety is a core value. It has clearly been attended to over the past 25 years, and some safety measures should be incorporated into every APM. And I encourage you to think about the Pygmalion effect, this idea that if we expect patient safety to improve, if we anticipate and motivate organizations to improve safety, then they will do so. Pygmalion effect. Second, a balanced approach is necessary across multiple measures. Really incorporating the idea that any single measure can be gamed, and we need to perhaps focus on measures that may be most sensitive to the financial incentives built into the program. So if the program incents reduced use of post-acute care inpatient rehabilitation care, for example, then we have to look specifically for harms that may result from underuse of that care. So a balanced approach to measures. Third, how much to put at stake? Well, I would suggest the Goldilocks principle. Not too much, not too little. It should be a graded incentive, not an all or nothing approach, but an amount that seems commensurate to the magnitude of harm. Fourth, we want to promote innovation in infrastructure and measurement. So we've heard a lot about the potential of real-time measures, whether we call them ECQMs or DQMs. We've heard about AI tools. We've heard about the need to incorporate patient perspectives, measures focused on diagnostic delay or diagnostic miscommunication. So let's promote innovation in the infrastructure and in measurement. Fourth point. Fifth point is to ensure that providers are engaged from the bottom up, really aligning actionability with accountability, so that when providers are accountable, they also have the ability to act, aligning those intrinsic motivations that we all have as professionals with the extrinsic motivation. And here I would keep in mind the Sisyphus principle. We don't want to feel like we're always pushing the rock uphill. We want to feel like we're making progress and that we can achieve the goals that are set out for us. And final sixth point is always consider and measure the unintended effects, whether it's voluntary withdrawal, underreporting, risk avoidance, gaming. These effects have to be anticipated from behavioral economics, have to be incorporated and measured. So 6 final points: safety in every APM, Pygmalion effect, a balanced approach with multiple measures, the Goldilocks principle, not too much, not too little, promoting innovation, infrastructure, and measurement, ensuring that providers are engaged, the Sisyphus principle, and finally, always measuring and considering unintended effects. So thank you for the opportunity to join.
Thank you, Dr. Romano. With that, I'll check with the host before we move on. Are there any other people who've signed up to give a public comment? I believe Sue. Great, thank you. Hearing none, that's the end of the public comment period. Now the committee will discuss everything we learned yesterday and today based on this public meeting. PTAC will submit a report to the Secretary of HHS with our comments and recommendations on targeting improvements in patient safety through alternative payment models. Committee members, please refer to the potential topics for deliberation document during this discussion. If you have a comment, please flip your name, or for our virtual committee members, please raise your hand in Zoom. Who would like to start? I might just start calling on people. No, just kidding.
Jenny, I can go.
Go ahead.
All right. Building a little bit on our conversations from the last 2 days, I think there's lots of compelling reasons why the issue needs attention and why the issue needs payment. I think there were clear arguments made for why innovation is needed and why there may be technologies that exist or are being developed that could materially change things, especially as you think about the role of AI in early detection and warning systems. I think I was struck by the fact that there's probably some ways in existing models, as folks talked about, to shine the spotlight on safety, perhaps choosing existing quality measures that touch on safety. And I think we heard from that from Susanna yesterday, talking about some of the focus on medication reconciliation measures and how that would promote avoidance of errors. I do think overall something mandatory is needed. I think the question is it, where does that payment come from? I heard the thing that would be the most helpful is the idea of payment to invest in the infrastructure itself, the data, the tech, and the capability for safety as opposed to penalties for current unsafe environments. I think I heard two strategies around prospective payments and potentially regulatory intervention. I still haven't really heard a concrete payment model, although there's hope that there could be a payment model, which makes me think there's more development needed before moving forward. I would acknowledge, though, I think as our previous commenter just shared, we really need to think about the administrative burden, the cognitive overload, and the operational fragility of the system we're working with when we talk about adding on just one more thing, even if it is a very noble cause. And I would also say that when we think about delays in payment or withholds, for many systems, those are, in fact, a penalty. So with all of the comments about needing to think beyond penalties, I think we need to be cautious with saying that a withhold is not a penalty. And then I think just maybe echoing the commenter most recently, there do seem like there's options for aligning APMs with existing certification programs that are out there as opposed to designing things that are entirely new, which would be an interesting place to start.
Next. Krishna?
Yeah, I guess my reflections the last 2 days, for me, like insofar as the payment models are a sort of manifestation of our priorities. Essentially, it's a way for us to align incentives to what we as a society want our care delivery systems to focus on. To me, I think figuring out how to reintroduce this focus on patient safety makes sense to me. So, I mean, it sounds like we've tried to do this for the last 25 years. It's not working. And so reinvigorating, refocusing feels like a very logical outcome after the 2 days of discussions. Of course, how we do it, how much, how wide, how, punitive, not punitive, is it mandatory, is it not? Those are all mechanics of any payment model that we have to sort of work through in the process. For me, as I reflect, the sort of the yes and approach feels logical, like, figuring out how to introduce patient safety sort of parsimoniously in existing models. Obviously, if you need to reduce the burden by minimizing some other measures that exist, fantastic. That's a path for us to take. And then if that doesn't work or doesn't have the effect at scale that we are hoping to have, how do we create a sort of focused attention on dedicated patient safety models is a logical path for me. And certainly amping up the intensity, whether it's a mandate, withhold, I mean, those are all further sort of levers we can pull broadly. So anyway, so my broad takeaway was we need to do something. It just feels like this is a problem that we've not made enough traction as a country. And then starting with the sort of the chassis we have approach and then evolving into a more dedicated focus would be logical sort of paths for us to convert this sort of energy and passion into action and improving the system. So.
Lee?
Sure. Appreciate those comments and agree. I guess I've got some things I've heard that I want to emphasize, some other things that I've put thoughts together, but I guess in my notes I'm seeing that I really did find it compelling that perhaps the only way to make a mistake here is to not try something. We see the reality of the system that we've built today, and we're deciding that status quo is not acceptable. And so while there is risk in trying something new, I think there's equal or worse risk to not trying something new, right? And so the path, though painful, though complicated, though there will be unintended positive and negative effects of a trial, I think to improve anything, we must change something. And so I think I'm in the state of being predisposed to action and trying to do better, right? Status quo is the only wrong choice. I do think we heard pretty compelling arguments that the policy tools and the legal framework exist, that something could be tried, and that was a position we're not often in, so that's great. I do think I've heard compelling discussion that we probably need to make something mandatory in some fashion, right? And there's kind of a new willingness to consider that. I wonder if we use mandatoriness as a policy tool in and of itself. Perhaps it's, you do get more flies with honey than with vinegar, and yet people will simply opt out if it's too challenging or they have too far journey to go. So perhaps it's mandatory for any new APM would be mandatory for, making this up, the bottom quartile of patient safety mechanisms, and then it's a bonus incentive for those that are already at the median or doing better, right? We can pull those levers independently. Doesn't have to be mandatory for the universe necessarily, right? I do wonder about kind of a two-tailed model, like I was saying, where it's almost an upside bonus for those already doing okay at patient safety, median or above, while it's a downside risk loss prevention mechanism for those that are doing the worstest, right? Those incentives might hit differently. I think we've heard some pretty good conversation about we do want it to be of a magnitude that it's sufficient enough that it can't be ignored, right? The pain of just taking the fee or the penalty is worse than not trying, and so that would have to be graded in a developing model. I think we heard some information about care coordination and transitions of care are probably the single largest safety domain that we have plenty of evidence base and plenty of PTAC conversation about what constitutes good care coordination and transition of care. And yet those aren't typically built in as required or mandatory metrics in CMS and CMMI's panoply of potential models. And so those might be specific measures to consider featuring prominently. And then I guess I appreciate Dr. Romano's 6 actionable steps, and I'm very happy those were read into the record. I guess I'll just end in a lot of conversation about, again, this is not technical, it's not data, it's really more about culture. And having done a few culture change projects in operations at health systems over my career, culture change is slow, measured in years, and incremental, always. And so I think we have to think about that both in baking safety into every existing model, as well as any unique specific model, that we have to have a multi-year time horizon to this project and have the incentives, either upside or downside, gradually step up in both bonus or severity over that time period. It's never going to be a one-year act. So, thank you.
Larry, and then Lauren.
Get off of mute there. Well, my comments are going to be somewhat similar to what we've heard, but I have to open by saying I appreciate the passion that was expressed by both Sue as well as Sam on having the patient and the administration spaces as a pull on the system represent maybe a unique opportunity for us. But as we have said, safety is not a standalone issue. It most often results from system failures. We heard a lot of anecdotal examples of what can occur when there are these failures, but they reflect the tip of the iceberg of systems failure. What we also heard very clearly is that we are at a technological revolution. The advances in AI may be creating an inflection point for us in the implementation of care redesign. The elephant in the room is culture. Culture needs to change not only on an individual, but on a team-based basis. I like the concept that patient safety needs to be part of every value-based care model, but we know that EHR integration needs to be part of every model. Patient engagement has to be part of every model. Care coordination has to be part of every model. Payment models have to be structured correctly. This is not a one issue problem. And maybe my major conclusion I've come to from this meeting is that PTAC is at an opportunity in its roadmap that it's developing for September. And maybe our major focus at this point should be to take all the work we've done and craft the correct structure of a value-based care model so that it includes all of these things that we have learned through the course of our sessions over the last few years, so that we can present the secretary with a structure that brings in all of these components instead of focusing on one.
Lauren.
I'm going to add on to some of the comments that have been made. So we've heard really important stories about harms that have happened. I've experienced that in my own family, and we also heard really strong data about how harm is continuing to happen in the healthcare system. So it's really clear that this level of harm is unacceptable. There's no clinicians who want it to be this way. Individually, we don't want it to be this way, but we are in a dichotomy where we are up against, and I'm going to quote one of the speakers, safety as a non-revenue generating cost center. That's significant in light of the economics of our health systems today with some of the changes going on. So in order to overcome that dichotomy, we've heard very clearly that this is about cultural change. It's really important to expand this across the ambulatory space. It's not only hospitals. It's not only in the primary care office. It's across multiple services, and that we have to attend to the real challenges in the workforce itself with administrative burden, stress, and really having the right information at the point of care to make decisions. We've heard core components of doing this well in patient safety is longitudinal care coordination, interdisciplinary team engagement, also a thread of the integration and attention to behavioral health, mental health, and substance use populations. And core components of design that result in change are learning systems and a focus on safe system design like aviation has done deeply. So some of the real opportunities I heard in the presenters during this 2-day session was real-time patient reporting. What's different that we have now compared to previous safety initiatives is the integration of AI and expansion of technology and the ability to potentially put in place prospective systems and continuous risk assessment. It's clear there needs to be rewards rather than penalty as part of the system in order to move change. And one of the great examples someone brought up is the investments in meaningful use resulted in huge transformation and integration of electronic health records. So I think we have an opportunity to look at what investment will motivate change across the states.
Thank you. I'll end with my quote that struck me today, besides the one that from Sue, is that absence of measurable harm is not necessarily the presence of safety. And when I think about what I feel we've learned over the last 2 days is that we have a very complex, huge country, very varied and very hard to move. We've tried to move this for 20-some years, and I believe the movement has to come both bottom up and top down. And when you think about bottom up, it really entails, do we have the right measurement, and really studying that and making sure we do. I think multiple speakers spoke about alternative ways to measure, speaks about data and how interoperable, real-time, predictive, prospective data can exist. Our stakeholders are patients. listening to what patients can give us and using the power of AI to really synthesize and syndicate that data to make it actionable. And then thinking about training. I really liked what one of our public commenters spoke about, Ms. Hoxie, about using current mechanisms for training providers as well as physicians in various specialties and hospitals, current certification mechanisms, and making sure we have that already a little bit, but putting a focus on it to train. To me, that's sort of the bottom up. And embedding it into current APMs to some degree. Then I think about the top down, and everyone's spoken about strategy, and one of my favorite quotes is culture eats strategy for breakfast. And if you don't have a top down initiative that comes from CMS, the director, and all of the leadership, I do believe that this gets lost and there's not national attention on it. And that top down from our committee's perspective is really setting up, in my mind, a framework for what Lee mentioned yesterday, and or. Is there a way that we can embed this into multiple levels on the bottom up and what already exists as chassis? And then is there a new initiative, new model, similar to the health tech ecosystem that gave birth to the pledge for, kill the clipboard? So I think there is a top-down way that we really need to be bold about and address and not accept the status quo. And that would be my, my take on the last 2 days. Lauren, did you want to say something?
I forgot one thing in my comments that I think is really important that Sue brought up. So an opportunity that we have not traditionally thought about and really deeply included is to design the systems that capture at the point of care the patient voice and family voice, to identify risk in the moment and make identifying risk and elevating it safe for patients and families, so that when things are noticed and can proactively be identified, that doesn't result in abandonment from the system or being labeled by the system. The patient voice and family voice is really, really critical in this dialogue.
Anybody else? Thank you to all the committee members for sharing your very valuable comments from across our 2-day meeting. Before closing, I would like to check with the ASPE staff to see if there are any clarifying questions for us. Marcia, Steve, do you have any questions? I want to thank everyone for participating today. Our session experts, my PTAC colleagues, and those who have joined us in person and online to listen in. We explored many different topics regarding targeting improvements in patient safety through alternative payment models. Special thanks to my colleagues on PTAC. There's a lot of information packed into these 2 days, and I appreciate your active participation and thoughtful comments. The committee will work to issue a report to the Secretary of HHS with our recommendations from this public meeting. And with that, one final thank you to the committee and session experts for joining us to make this a memorable and informative PTAC public meeting. This meeting is now adjourned.
Produced by the U.S. Department of Health and Human Services.